Usually when you look at a medical blueprint, it's pretty static. You know, you lay the foundation, you frame the walls, the plumbing goes exactly where the schematic says it should go.
Right, the blueprint doesn't just change once the cement is poured.
Exactly. But when you step into the world of human pregnancy and, well, obstetrics in general, you basically have to throw that static blueprint out the window.
You really do. It's a completely different paradigm.
Yeah, because we're looking at a biological landscape where the house is actively redesigning its own blueprint while it builds itself, you know? It's
Yeah.
constantly adapting to whatever environment it finds itself in.
It is the ultimate dynamic system. And the sheer complexity of it is exactly what we're going to get into today. Welcome to the deep dive, everyone.
Yes, welcome. Today, we are using an incredibly foundational medical text as our guide. We're looking at Obstetrics, 20th edition by 10 teachers.
Edited by Professors Louise C. Kenny and Jenny A. Myers. It really is a seminal text.
It is. And our mission today is to give you a comprehensive, high-yield guide to this biological marvel. Whether you're a medical student, a young professional, or just, intensely curious about how we all got here.
Because in obstetrics, you aren't just treating a static condition. You're managing the physiology of two distinct patients at the exact same time.
Right.
And one of those patients is entirely hidden from the naked eye, just developing in this highly reactive parallel universe.
Which is wild to think about. And to even begin monitoring that hidden patient, you have to know exactly when the construction starts. You have to set the clock.
Setting the clock is everything. It's step one.
But historically, the medical standard for dating a pregnancy was the LMP, right? The last menstrual period. But looking through the clinical guidelines in this text, it seems like the field has aggressively moved away from that.
Oh, absolutely. The LMP is, well, it's treated almost as guesswork now.
Really? Why is it so unreliable?
Because human biology is wonderfully messy. The LMP method relies on an assumption of perfect biological regularity. And that just simply doesn't exist for most of the population.
Right, because calculating the delivery date based on the LMP assumes what? That every woman has a perfect 28-day cycle.
Exactly. It assumes a perfect 28-day cycle, and it assumes that ovulation happens exactly on day 14.
Which is practically a myth. I mean, cycle lengths vary wildly from person to person.
You do. And think about the external factors. If someone recently stopped using oral contraceptives, or if they're still breastfeeding a previous child, that timeline is completely thrown off.
It's totally warped. So the stakes for getting that timeline right, I imagine, are incredibly high.
They're massive. Because if you base crucial medical decisions on an inaccurate timeline, you risk intervening prematurely.
Like inducing labor when the baby isn't actually full term.
Exactly. Or on the flip side, you might miss severe signs of delayed fetal growth because you just think the baby is younger than it actually is.
Oh, wow. Okay, so you think they're fine, but they're actually severely restricted.
Right. And that is exactly why the clinical standard has shifted to ultrasound, specifically measuring the fetal crown rump length, or the CRL.
A CRL. So you're basically measuring the fetus from the very top of the head down to the bottom of the torso.
That's right.
But the window for doing this, it's strictly defined in the textbook as being between 10 weeks and 0 days and 13 weeks and 6 days. Why that very specific 4-week window?
It all comes down to biological uniformity. You see, before 10 weeks, the embryo is so small, and its degree of flexion, meaning how much it's curled up, it varies so much that the measurement can be really inaccurate.
Okay, so it's too curled up to get a straight line.
Exactly. But between 10 and 14 weeks, human fetuses grow at a remarkably uniform rate, regardless of their genetics.
Wait, really? So a baby that will eventually be like a 6'5" adult and a baby that will be a 5'2" adult, they grow at the exact same speed in that specific window.
Precisely. It is only after 14 weeks that individual genetic potential really kicks in, and babies start growing at different rates.
Oh, I get it. So if you try to date a pregnancy at, say, 20 weeks, and the baby measures small.
You have no way of knowing why. Is the timeline wrong? Is the baby just genetically small? Or is it suffering from severe growth restriction? You just don't know.
That makes total sense. So that first trimester crown rump length is the undisputed gold standard for setting the biological clock.
It absolutely is. But, setting the clock is only part of the initial assessment.
Right, because when a clinician takes an obstetric history, they aren't just logging biological data, are they? They're assessing the entire environment.
The entire social and physical ecosystem. And some of the data on social environments is just staggering.
It really is. The book mentions the UK confidential inquiries into maternal deaths and morbidity. And the statistic that stood out to me, it's incredibly heavy, is that 1/3 of women who experience domestic violence are hit for the very first time during pregnancy.
Yeah, it is a sobering reality, and it completely redefines what an obstetric history must be.
Because why does that happen? Why does pregnancy trigger that?
Well, pregnancy is a period of immense psychological, financial, and physical stress. For an abusive partner, the shift in attention away from them and toward the impending child, combined with the extreme physical vulnerability of the pregnant patient, it frequently acts as a trigger for violence.
It fundamentally changes the role of the medical provider, doesn't it? I mean, you aren't just checking blood pressure anymore. You're evaluating the safety of the entire environment.
You have to. Pregnant patients experiencing domestic abuse are at a drastically higher risk for missed antenatal appointments, severe psychological trauma, and direct physical harm to the fetus.
Like placental abruption, where the placenta literally tears away.
Exactly. It's why clinical history taking requires immense sensitivity. You have to actively screen for domestic violence. So it's a non-negotiable part of care.
And that environment, both outside the mother and inside the uterus, it literally shapes the physiological future of the fetus. Which brings us to a really fascinating concept in the text, the Barker hypothesis.
Ah, yes. The thrifty phenotype.
Right. And the best way I can visualize this is, well, think of the developing fetus like a brand new smartphone.
Okay, I like this. Go on.
If that phone senses it isn't getting enough power from the charger, it doesn't just keep running at 100% until it dies. It permanently alters its hardware to run on low battery mode.
Right, to conserve energy.
Exactly. It dims the screen, it slows the processor down, it shuts down all the background apps.
That is an incredibly accurate analogy, because the Barker hypothesis proposes that if a fetus experiences a restricted intrauterine environment, meaning it has a limited supply of nutrients or oxygen due to, say, poor placental function or maternal stress, it makes permanent physiological adaptations.
To ensure its immediate survival.
Yes, the fetus realizes resources are scarce and it just starts prioritizing.
The body's brilliant, but it's ruthless.
Yeah.
Right.
Oh, completely ruthless. It shunts whatever limited oxygen and nutrients it has directly to the brain and the heart.
Because you can't live without those.
Exactly. Those organs are non-negotiable. But it does this at the expense of visceral organs. Blood flow is physically diverted away from the pancreas, the liver, and the kidneys.
Wow.
And because this happens during such a critical window of development, the actual tissue structure and the epigenetic programming of those organs are permanently altered.
Wait, okay. So if the fetus is permanently shutting down capacity in the liver and pancreas to save the brain, what happens when that baby is born into a world where food is everywhere?
That is the crucial question. And it's exactly the mechanism behind the danger.
Their organs must be completely overwhelmed by the metabolic load, right?
They are. Their physiology is permanently programmed for a world of absolute scarcity. So if they are born into a normal environment with abundant calories, their low battery mode organs just can't handle the load.
Especially the pancreas.
Right, the pancreas, which produces insulin. This is why restricted fetal growth directly, causally correlates to adult chronic conditions.
Like heart disease.
Yes. We are talking about severe increases in the risk of coronary heart disease, stroke, and type 2 diabetes decades later. The intrauterine environment is literally writing the software for their adult metabolism.
That is wild. We are essentially setting the stage for a 50-year-old's heart attack before they even take their first breath.
It's a profound realization for preventative medicine.
Unbelievable. Okay, so to monitor that critical environment, we obviously have to look inside. And this brings us to the fetal circulation, which, reading through the text, operates on entirely different physics than adult circulation.
Because the fetus isn't breathing air yet, so the plumbing has to be completely rewired.
Right. In an adult, the heart works in series. The right side pumps deoxygenated blood to the lungs to pick up oxygen, and then the left side pumps that newly oxygenated blood to the rest of the body.
But if fetus's lungs are collapsed, they are totally filled with amniotic fluid.
Which means the resistance to blood flow in the lungs is incredibly high, right? Like
Right.
pushing water against a brick wall.
Exactly. The pressure in the pulmonary system is massive. And basic physics tells us that fluid takes the path of least resistance.
So if the lungs are a high-pressure zone, the blood is going to look for a shortcut.
And the fetal anatomy provides 3 highly specialized shortcuts. We call them shunts.
Okay, let's walk through them. Where does the oxygen come from first?
The oxygen-rich blood comes from the placenta, and it enters the fetus through the umbilical vein. But instead of being bogged down going through the liver, A large portion bypasses the liver sinusoids entirely through the first shunt.
Which is the ductus venosus.
Yes. The ductus venusus shoots that oxygenated blood straight into the inferior vena cava.
So it hits the right atrium of the heart, but again, it really doesn't want to go to the lungs.
No, it
Yeah.
doesn't. Because of that high pressure in the lungs, the blood in the right atrium looks for an escape route, and it finds the second shunt, the foramen oval.
Which is literally a hole between the right and left sides of the heart, right? A flap valve.
That's exactly what it is. The highly oxygenated blood shoots straight across from the right atrium into the left side of the heart, and from the left ventricle, it gets pumped straight up to the coronary arteries and the brain.
So the system basically guarantees the brain gets the absolute most oxygen-rich blood available.
Right. It prioritizes the brain perfectly.
Yeah.
Meanwhile, the deoxygenated blood returning from the baby's upper body enters the right atrium, drops down into the right ventricle, and gets pumped toward the lungs.
But it hits that high-pressure wall again?
Yes. So it takes the third shunt, the ductus arteriosus. This connects the pulmonary artery directly to the descending aorta,
Bypassing the lungs entirely.
bypassing them entirely. The blood heads down to the lower body and flows back to the placenta to be reoxygenated. So the right and left ventricles are actually working in parallel, not in series.
It's an engineering marvel, seriously. But here's where I have to push back a little bit on how we observe this.
Okay, go ahead.
We have this delicate, highly calibrated parallel universe. And to check on it, we fire high-frequency sound waves into the uterus using ultrasound.
Yes, we do.
The textbook explicitly notes that ultrasound generates thermal and mechanical energy. High-frequency sound waves cause tissue molecules to vibrate, and vibration equals friction, which equals heat.
That's basic physics, yes.
So how do we know we aren't, well, cooking the very environment we are trying to monitor?
That is a completely valid concern, and the medical community takes the physics of ultrasound extremely seriously for exactly that reason. When Professor Ian Donald first pioneered obstetric ultrasound back in 1959, the focus was just on, getting an echo, getting an image.
Sure, just seeing if the tech worked.
Right. But today, the focus is heavily on safety, and it's governed by the ALARA principle, ALARA, which stands for as low as reasonably achievable.
Meaning you only use enough acoustic power to get the job done, and then you get out.
Exactly. Modern ultrasound machines constantly display a thermal index and a mechanical index right on the screen. The thermal index estimates the potential temperature rise in the surrounding tissue.
And I imagine early in the pregnancy, that's incredibly dangerous.
Very. In the first 10 weeks of gestation, the embryo is undergoing intense organogenesis, the actual formation of organs. It is highly susceptible to thermal injury.
So you can't just linger there.
No, clinicians are strictly mandated to keep examination times as short as absolutely necessary. You do not leave the probe hovering over an early embryo just to get a prettier picture for the parents. It's a calculated medical procedure with actual physical forces at play.
Okay, that makes me feel better about the technology. So assuming the baby develops safely, the parallel plumbing is working perfectly. Eventually, the baby has to exit that parallel universe.
It's time for parturition.
Lever!
And reading through the mechanics of this, it is an intense physical engineering problem. The textbook breaks it down into the 3 Ps. Yes, the 3 Ps are the absolute foundation of a normal vaginal delivery: powers, passages, and passenger.
Let's look at the mechanics of each of those, starting with powers.
Powers refers to the literal forces at work. The primary uterine contractions that pull the cervix open and push the baby down. And that's supplemented later by the maternal skeletal muscle effort, the act of pushing.
And then the passages?
The passages is the birth canal itself. It's a combination of the bony pelvis, which is completely rigid, and the pelvic floor muscles and perineal tissues, which must stretch to accommodate the baby.
And finally, the passenger is obviously the fetus.
Right, but this isn't just about the baby's weight. It is heavily about the presentation, meaning which anatomical part is leading the way, and its position and attitude relative to the maternal pelvis.
Because when the powers, passages, and passenger meet, we get the mechanism of labor. And the human pelvis is honestly a bizarre shape.
It is unique in the animal kingdom.
The inlet at the top is a wide oval from side to side, but the outlet at the bottom is an oval that is wide front to back. And the baby's head is also an oval, so it can't just slide straight down like dropping a coin in a slot. It has to perform a highly specific sequence of twists and turns to fit.
This sequence is called the cardinal movements of labor, and it is an absolute masterclass in biomechanics.
Walk us through it.
It begins with engagement, where the widest part of the fetal head enters that side-to-side pelvic inlet. Then comes descent, which is just a continuous downward movement.
But as the head descends, it hits the pelvic floor, right?
Exactly. It hits the resistance of the pelvic floor, and it undergoes flexion. The baby's chin tucks tightly down to its chest.
Which changes the geometry entirely, because by tucking the chin, it presents the suboccipitobrachmatic diameter.
That's a mouthful, but yeah.
It's basically the absolute smallest circumference of the skull, so it tucks its chin to fit better.
Precisely. Once flexed, the baby hits that transition where the pelvis changes shape.
Mm.
Remember, the outlet is front to back.
Yeah.
So it must perform internal rotation. The head rotates 90 degrees, so the back of its skull, the occiput, is facing the front of the mother's pelvis. Now it fits perfectly into the front-to-back shape of the outlet.
Okay, so now the head is ready to exit.
Right. The head passes under the mother's pubic bone in a movement called extension. The back of the head anchors underneath the symphysis pubis, which essentially acts as a hinge. The head extends backwards, allowing the face and chin to just sweep out of the birth canal.
So the head is out, but the baby's shoulders are still inside, and they are still aligned with the side-to-side inlet higher up.
Which means the baby must immediately perform restitution and external rotation. The head untwists outside the body to realign with the shoulders inside, and then the entire body rotates 90 degrees so the shoulders are now front to back.
And then they can slip under the pubic bone.
Yes, one at a time. Anterior shoulder first, then the posterior shoulder.
It's an incredible, intricate lock-and-key sequence. But what happens when that sequence slows down? Like, when the powers aren't strong enough or the passage is too tight? Lay people, and honestly medical dramas on TV, they love to throw around the phrase fetal distress.
Oh, they do, all the time.
But the textbook aggressively avoids that term. Why the semantic shift?
Because fetal distress is clinically vague, it's heavily emotional, and very often it's completely inaccurate. The correct medical terminology is suspected fetal compromise.
And the word suspected carries a lot of clinical weight there.
It does. It dictates the medical response.
But why only suspected? I mean, if you're looking at a fetal heart rate monitor and the heart rate is dropping like a stone, isn't the baby suffocating?
Not necessarily. And this is where understanding the underlying physiology is so critical. We use cardioechographs to monitor the heart rate, and we look for meconium, which is the baby's first stool in the amniotic fluid.
Right. Those are the standard warning signs.
But both of these indicators have a massive false positive rate for actual hypoxia.
Hypoxia being an actual lack of oxygen at the tissue level.
Exactly. Or acidosis, which is a dangerous shift in the baby's blood chemistry.
So the alarms are ringing, but there's no actual fire.
Frequently, yes. Let me give you an example. When the uterus contracts, it physically squeezes the baby's head. That compression stimulates the baby's vagus nerve.
Okay.
And stimulating the vagus nerve triggers a reflex that slows the heart rate down. It is a perfectly normal physiological vagal response. It is not a sign of asphyxiation.
Wow. And what about the meconium?
Similarly, a baby might pass meconium simply because its digestive system has reached maturity. It doesn't inherently mean the baby's in distress.
So if you use panic terminology like fetal distress based on a completely normal head squeeze, you might end up rushing a patient into an emergency cesarean section for absolutely no reason.
Exactly. Precision in language dictates precision in care. You must differentiate between a physiological reflex and pathological compromise. Otherwise, you trigger a cascade of unnecessary and potentially dangerous surgical interventions.
That makes a lot of sense. But causality goes both ways, doesn't it? You have this high false positive rate, meaning alarms ring for no reason. But when the mechanics actually do fail, when it is not a false alarm, the shift from a normal delivery to a life or death emergency is almost instantaneous.
It is incredibly fast. Obstetrics can go from perfectly routine to code blue in seconds.
Let's look at some of those actual failures. Starting with a condition that used to be a relentless killer of newborns, but is now entirely preventable. Rhesus isoimmunization.
Yes. This is a spectacular triumph of modern immunology. So every person has a blood type, and part of that type is the rhesus or Rh factor. You're either Rh positive or Rh negative.
And the emergency cascade begins if an Rh negative mother is carrying an Rh positive fetus.
Exactly. Because the mother's immune system doesn't inherently recognize that Rh positive protein on the baby's red blood cells.
It sees it as a threat.
Right. During pregnancy, and particularly during the physical trauma of delivery, a small amount of the baby's Rh positive blood can cross the placenta and enter the mother's bloodstream.
And the mother's immune system spots these Rh positive cells, identifies them as foreign invaders, And mounts a defense.
It becomes sensitized. It produces antibodies specifically designed to destroy them.
But this process takes time, right? The text mentions that the mother initially produces large IgM antibodies, which are physically too big to cross the placenta.
That's right. So the first baby is born safely, before the mother's immune system can mount a real attack.
But that's the tragic trick of the disease, isn't it?
It is. The first baby is fine. But the mother's immune system now has memory B cells. If she gets pregnant with another Rh-positive baby, her immune system immediately produces IgG antibodies.
And those are much smaller.
They are. They cross the placenta with ease. They seek out the fetus's red blood cells and obliterate them. This causes hemolytic disease of the fetus and newborn, which leads to profound fetal anemia, heart failure, and death.
It's devastating. But the textbook outlines how we stop this entirely now using anti-D immunoglobulin. How does that actually work?
By administering prophylactic anti-D antibodies to the mother during pregnancy and immediately after birth, we are basically injecting a specialized cleaning crew into her bloodstream.
Okay, I like this. A cleaning crew.
These injected antibodies find any fetal Rh-positive red cells that have crossed over, and they bind to them, masking them completely.
Oh, they mop up the fetal cells before the mother's own B cells even realize they are there.
Exactly. Her immune system never gets sensitized. We stop the cascade before it even begins.
We hide the invaders before the security cameras see them. That is incredible.
It's one of our greatest medical victories.
Let's move to a mechanical emergency. Arguably the most terrifying scenario on a labor ward. Maternal collapse. The pregnant patient becomes completely unresponsive. And performing CPR on a pregnant woman relies on overcoming a massive anatomical hurdle, doesn't it?
It does. It comes down to profound hemodynamic changes. A pregnant woman at term is carrying a massive amount of weight in her abdominal cavity. You have the fetus, the placenta, the amniotic fluid, and the enlarged uterus itself.
Which brings us to the physics of aortocaval compression. The best way I could visualize this while reading was, imagine parking a heavy car on top of a garden hose.
Okay.
The heavy uterus is the car. And the mother's inferior vena cava, which is the primary vein returning deoxygenated blood from the lower body back to the heart, is the garden hose.
That is a perfect visualization. Because if an unresponsive pregnant woman is laid flat on her back for CPR, the entire weight of that gravid uterus crushes down on the inferior vena cava.
It completely squashes the garden hose.
It does. And this physically blocks venous blood return to the heart. Now, cardiac output relies entirely on preload, meaning the blood entering the heart.
Right, the heart can only pump what it receives.
Exactly. If no blood gets back to the heart, it doesn't matter how perfectly you perform chest compressions. The heart is empty. It has nothing to pump.
So the mechanics dictate the solution. You have to get the car off the hose.
The immediate life-saving clinical mandate in maternal resuscitation is applying a left lateral tilt of 15 to 20 degrees. You literally physically tilt the mother's entire body to the left or manually push the uterus over to the left side.
And that relieves the compression on the vena cava?
It restores blood flow to the heart and makes CPR hemodynamically effective. Without that tilt, resuscitation is absolutely doomed to fail.
It's such a simple mechanical fix, but it's the difference between life and death. Let's touch on one final mechanical failure. We've talked about the baby getting out, but what happens when the uterus itself fails to behave during the third stage of labor? I'm talking about uterine inversion.
Oh, uterine inversion. This is a visceral, truly terrifying emergency.
It sounds horrific.
It is a profound obstetric crisis where the uterus literally turns inside out, pulling through the cervix during the delivery of the placenta. It happens through a combination of altered physiology and physical force. Specifically, it happens when the uterus is hypotonic.
Meaning the uterine muscle is relaxed, it's boggy and exhausted instead of clamping down firmly like it should after birth.
Right. If the uterus is hypotonic and a clinician applies traction, meaning they pull on the umbilical cord to try and deliver the placenta before it is naturally detached, the placenta stays anchored to the uterine wall.
Oh no. So the pulling force drags the top of the uterus down.
It drags the fundus down into the uterine cavity, literally turning it inside out. It can completely invert and protrude outside the vagina, causing massive hemorrhage and neurogenic shock.
And physiologically, you cannot wait to fix this.
Prompt manual replacement is absolutely critical. You must physically push the fundus back up into its normal anatomical position immediately. And you do not remove the placenta yet, because that will severely worsen the bleeding.
And what happens if you wait too long?
If you wait, the cervical muscles will start to spasm and clamp down around the inverted tissue, forming what's called a retraction ring. Once that muscular ring acts like a noose, you cannot push the uterus back up without powerful general anesthetics to paralyze the muscle or emergency surgery.
When you step back and look at everything we've covered today, it really does come down to basic physics, mechanics, and plumbing, doesn't it?
It absolutely does.
Whether it's the high pressure resistance in the fetal lungs dictating the shunts of that parallel universe, or the geometric puzzle of the fetal skull navigating the maternal pelvis.
Which is exactly why, as educational guides, we want to ensure you aren't just memorizing facts, but truly understanding the mechanisms. If you are on a clinical ward tomorrow and a pregnant patient collapses in front of you, you don't need to panic.
You just remember the physics, you remember the garden hose.
Yes. In fact, to test your clinical recall today, I have a quick exercise for you. If a pregnant patient collapses in your care, what specific physical adjustment must you make to her position immediately? And what underlying anatomical issue does this action solve?
I've got this one. You apply a 15 to 20 degree left lateral tilt to relieve aortocaval compression and restore venous return to the heart.
Spot on. The physiology guides the action. And before we close, I want to leave you with one final thought to ponder. A profound concept that stems from the Barker hypothesis we discussed earlier.
Oh, about the thrifty phenotype and fetal programming.
Yes. If the Barker hypothesis is true, that the intrauterine environment permanently programs our susceptibility to adult conditions like heart disease, stroke, and diabetes,
Right.
then is the true frontline of adult preventative medicine actually found in the antenatal clinic? Are obstetricians the original preventative cardiologists?
Wow. That completely flips how we view adult medicine. The blueprint really is dynamic, and it's written before we're even born.
It's a fascinating paradigm shift.
It absolutely is. Thank you for diving into this incredible biological landscape with us today.